The excellent results obtained with LASIK have clearly promoted its widespread success. This has come about as a result of progress made in the fields of excimer lasers and microkeratomes. It is for this reason that we can now offer the latest microkeratomes for the treatment of anterior opacities of the cornea. Until recently, this condition required either a traditional lamellar graft or a penetrating keratoplasty. Manual lamellar grafting is a long and delicate surgical procedure. Optical results are often affected by numerous sources of astigmatism, such as irregularities of the cleavage, irregularities of the lenticule, and such suture tension. Although from an optical standpoint, penetrating grafts are a superior technique, they do expose the graft to the risk of immune ejection during the initial post-operative years. Therapeutic photoablation is restricted to most anterior opacities. Nowadays, all these anterior opacities of the cornea are indications for automated lamellar keratoplasty. The artificial chamber developed here enables a corneal button to be used with its scleral rim. The corneal graft is positioned on top of the artificial anterior chamber with a locking system to ensure tightness. The applanation lens enables the diameter of the cornea to be calibrated using the adjustment screw prior to making the resection. The dovetail guide plate rests on the screw at the selected height. The microkeratome is identical to the one used for classic LASIK. It is moved manually. A stop ring is not used in order to create a free cap for keratectomy. Various suction rings are available. The artificial anterior chamber is connected to the hydrostatic system, thus maintaining the required pressure during lenticle removal. Before any surgical procedure on the actual patient, the corneal button is placed on the top of the artificial anterior chamber. The cornea is sealed and made leak-tight using the locking screw. The applanation lens with pre-calibrated circular markings enables the diameter of the donor cornea to be calibrated in order to match the sample taken from the patient, regardless of the radius of curvature or corneal diameter of the donor. Once the suction ring has been placed on the patient, a free cap is then made in the same way as for LASIK. The thickness of the keratectomy depends on which microkeratome head is used. In this case, using the 180 head gives a sample removal, approximately 220 microns thick. The diameter of the recipient bed is measured following both the horizontal and the vertical meridians, 8 millimeters in this case. When an applanation lens is used, the diameter of the corneal graft taken from the donor should be approximately 10% larger to allow for retraction of the corneal flap following sample removal. In the case of a particularly thin flap, a guide mark should be made on the epithelium. By using the same microkeratome, the lenticle removed from the donor will be the same thickness. The graft is placed on the recipient cornea, making allowances for any possible irregularities. The graft is fitted onto the recipient and carefully checked. Contention suture is used to hold the graft in place during the first few days. This suture must not be over tight in order to avoid wrinkling of the graft. This profile shows that factors likely to induce astigmatism have been reduced as much as possible. In the case of deeper pathology, thicker samples may be taken, provided keratome heads of 300 or 400 microns are used for both the donor and the recipient. In such cases, contention suture alone is insufficient. A technique combining 8 single sutures and one of running nylon will be required. These will be removed after 2 months. Early clinical results are satisfactory. The contention suture can be removed as from day 3, since adhesion to the flap is the same as adhesion to a cap with LASIK procedure. Optical results can be assessed a few weeks later. These UBM photographs show the regularity both of the corneal graft and cutting zone. It's possible to lift the cap 2 or 3 months after initial surgery in order to treat any residual refractive error using the excimer laser. This relatively simple technique, combining the cumulative advantages of LASIK lamellar graft and therapeutic photoablation, should help reduce the indications for penetrating grafts and treat, in a simple way, most cases of anterior opacities of the cornea.